Thank you for the kind introductions. My lectures is on advances in epilepsy surgery. This is a continuous lecture from yesterday. I will try to elaborate a little bit more by giving you some examples in epilepsy surgery assessments. So epilepsy surgery is proven to be more effective in refractory epilepsy as compared to pharmacological treatments. And this is a randomized control trial which has proven that epilepsy surgery has a better seizure freedom rate compared to medications. But nonetheless, we are facing a lot of challenges in epilepsy surgery, pre-surgical evaluations, as well as determinations of the surgical candidates. And we'll need a little bit more advances in investigations and managements to help us to manage these patients. These studies show that the utilizations of epilepsy surgery in our region is very limited, mainly limited by a few factors. For example, we doesn't have enough clinicians in some of our countries, especially in the Southeast Asian regions. We don't have adequate specialty or subspecialty training in epilepsy. There are lack of specialized centers as well as lack of facilities. I understand sometimes if there's only one EEG machines and the machines is spoiled and we may not have any more machines to monitor our patients. That's why I divide my talks into four components. The first one is non-invasive pre-surgical evaluations. Second one in invasive evaluations. Third one in the surgical treatment. And the fourth is in neuromodulations. So this is a map that I normally describe on how we perform or the flow chart of how we do assessments for someone who are refractory to pharmacological treatments. So we always started with pre-surgical evaluations consisting the EEG, MRI, and so on. And therefore, my topics will cover some of the new things in semiology, EEG, especially in EEG spatial, the investigations that can increase EEG spatial resolutions, the MRI advances and post-processing in the MRI images, the ambulatory EEG monitoring, as well as a PET scan. So let me start with semiology. Epileptogenic zone is an area of cortex that we need to resect to achieve seizure freedom. And it's usually decided by a few things. The first one is semiology, where the seizures is from based on the seizure descriptions. And then the second one is MRI, telling us where is the epileptogenic zones or lesions. The third one is an inter-ictal EEG, informing us the irritative zone. The ictal seizure or ictal onset zones based on EEG monitoring or ictal EEG. Functional deficit zones based on PET scan. And we need to decide the epileptogenic zones based on a combinations of various investigation modality. So sometimes it's not enough to depend on just one modality alone. And semiology is always the most cost-effective modality because it just depends on the history you have taken, observation of the seizure if there is a video recorded by the family members or friends, and it doesn't cost much to analyze those informations. And therefore, I always encourage people to talk about and to describe the semiology as many details as possible so that we can start our analysis based on semiology alone. So this is a course that we just had in Kuala Lumpur recently on semiology and neuroimaging. And we are going to organize this once a year or once every 2 years to improve our knowledge on semiology. But besides semiology, the next things we look at is EEG. Besides the normal EEG that we are recording and we are analyzing using our own eyes subjectively, there are many objective ways to look at EEG. So the first one is EEG source imaging. If you look at the picture, it's mainly analyze, getting the EEG data, compile them and average them, and then analyze the average waves according to the distributions in the brain, and then map it to a MRI. So in the old days, EEG is two-dimensional because we are only telling, oh, the seizure is coming from F3C3, which is two-dimensional maps of a frontal central region in the left. But which part of the frontal central in the left, we are not very sure. Is it the SMA? Is it the cingulate? Is it the motor cortex? Is it the lateral frontal gyrus or sulcus? We are uncertain. But if we can analyze the EEG and map them into a patient's MRI or template MRI, it will give us a better idea of three-dimensional distribution of the EEG source rather than the two-dimensional EEG that I've just mentioned. So this is an example. We have averaged the discharges, and you can see the discharges is at the C3 and CZ. And this is a voltage map that we have mapped of those discharges. And then we try to map these discharges to the source in the MRI region, and it mapped to a left supplementary motor area in which the patients had a asymmetric tonic seizure corresponding to the left SMA. Another way to understand or to improve the spatial resolutions of the EEG is to have more electrodes. And nowadays, electrodes are getting more and more and more. And these are called high-density EEG array. There is a machine in Bangkok. They are doing high-density array. And there are also some of the labs in Malaysia who use it for research. And you can see the number of electrodes on the picture itself. And it will give you a much higher resolution of where these EEGs are from. And then they will use this data and map it to the MRI to find the source of the EEG discharges. We can't do it for long. Patient have to sit there. Usually it's done for 30 to 60 minutes. EEG fMRI is another way to improve EEG resolutions. You can see that this patient is wearing an EEG and then was put in the MRI scanner, and normal electrodes are not MRI compatible. All our gold, platinums, they cannot enter the MRI scanner. So most of these electrodes are using carbon, which are MRI compatible. And you can map the discharges with a bold signal change. So what happened in the functional MRI is that there is an increased oxygenation during certain phase of the EEG recording. And you will see during the sharp waves here, during sharp waves here at C3, they map to increased bold signals in the functional MRI and tell us exactly where the discharges is coming from. It's also done for 30 to 60 minutes. It's available in Melbourne when I was trained there, and it's also available in Montreal and some of the other countries. The issue is not having the MRI machines itself, but is having the carbon electrodes so that we can record EEG in the MRI scanner. Ambulatory EEG is something that I've been pushing. We have organized many webinars. This is going to happen soon. In the old days, 10, 20 years ago, to do EEG at home, we'll have problem with resolutions of the EEG, artifacts, impedance problem, poor video recordings, and we will not be able to have a good records of EEG at home. Now, everything has been improved. There are many advancements. The EEG resolution is very good now. And you can see a high definition videos. We can record 180 degrees. The units that we are going to try on has two cameras capturing at two different angles. They can be put in the dining hall, can be put in the bedroom, and you can record for 3 days, 5 days, and the data can be transferred via Wi-Fi every day. So every day we will be able to review the EEG records, and patients doesn't need to be admitted to the hospital using ambulatory EEG. This is a common practice in a few countries, including Australia, and I think it's much more cost effective, and it will be useful for countries with less EEG, video EEG centers. So as you can see, the daily data is uploaded using Wi-Fi, and it is very cost effective. Now I'm going to MRI. Harness and protocol has been mentioned many times. Just to remind you, it's about volumetric. So we are taking every voxels or every cut in a thin manner so that we can capture the MRI in a three-dimensional way. This is a picture showing you how T1 and T2 helps in focal cortical dysplasia, and as well as other sequences. For example, FSEIR, which fast spin echo inversion recovery. And you can see that this new, it doesn't have to be 3 Tesla MRI. It can be done in 1.5 Tesla MRI. And these additional sequences actually take only extra 5 to 10 minutes in the MRI timing. And we can reconstruct them in 3 axes, the axial coronal as well as sagittal, and sometimes we can reorganize it in the hippocampal plane as well to look at the hippocampus for hippocampal sclerosis. So just give you an example of MTS, which I won't explain more because it was covered in the lecture just now. This is the mesial temporal sclerosis and focal cortical dysplasia. That is much clearer and easier to recognize if we do a thin cut volumetric sequence. So I'm going to explain the one that I mentioned yesterday about voxel-based morphometry, which is a post-processing. It doesn't cost extra to capture additional images. We are just using our current T1 volumetric images and putting it into a software to run it and to identify the lesions accordingly. So let me explain a little bit more. This patient have left sensory seizure. There is a subtle changes in the right parietal lobe, which was not very well seen in the T1 on the right. Over here, very subtle. But if we look at our post-processing image, it makes the gray-white junction blurring much clearer. So what is voxel-based morphometry? It is a way of putting one patient's MRI into an average of 50 to 100 normal MRI, and then we do comparisons voxels by voxels. We will be able to see the changes in the sulcus we call extension map, a deeper sulcus. We will be able to see changes in the gray-white junction we call junction map. We will be able to see abnormal thickness of the brain we call thickness map. So this voxel-based morphometry allow us to identify abnormal sulcus like bottom of sulcal dysplasia, abnormal gray-white junction like focal cortical dysplasia, as well as abnormal thickness in various forms of cortical malformations. So we are happy and encouraged that at least each country have one center running this. For us, it only take us 30 minutes. You send us the T1 images, we take 30 minutes. These images will come out, and we'll be able to analyze for you or send the raw data to you, and you analyze yourselves according to what your patient's informations are. This is another way of doing post-processing. It's called textual analysis. The software of textual analysis is free, but there is a cost that you need to attend because it takes longer and more complicated steps. Firstly, it identifies the gradient. You can identify area of this region where I highlight with yellow arrow, that the gray-white junctions, the gradient of the gray-white junction is blurry. Another way is to look for relative intensity. It just reverses the intensity of certain region to make the hypodensity area become more hyper, so that you can identify, there is a much clearer contrast of those abnormal regions and help you to identify suspicious. I'm not saying this is definite. It helps us to identify subtle and suspicious region and inform us whether this is likely to be abnormal or not. So this is a patient with left face clonic seizure. And of course, our mind always look at the right side. If you look at the right side face motor area, it seems to be fine. The frontal operculum, the motor cortex over the facial area looks okay on the right side. If I give you a clue, something is there on the left. Let me highlight to you. Something is there on the left because this patient lesion is on the left, but causing a left face clonic because of connectivity between left and right facial motor regions. It's not that clear, but if I give you a PET scan now, so PET scan is another advancement. If you can do core registration, it will help us to identify the regions that may have subtle MRI changes. So if you look back to the MRI, you may see that there is a lesion on the left side corresponding to the face motor area. And the histopathology, patient is seizure-free now. Histopathology show them desmoplastic infantile ganglioglioma. So PET imaging is inadequate if we don't do core registrations. Core registration means you put the PET and the MRI together so that you can overlap them and identify area that is suspicious. Let me give you this as an example. There's a subtle lesions on the left frontal regions. If you just do the PET, the surrounding cortex is hyper or normal metabolic. So it doesn't seem to have anything abnormal there. Until you core register them, you will see an area where there is a gray matter, but with PET hypometabolism. This is a bottom of sulcal dysplasia. We have done ECOG and the lesion was resected and just recently. The presentation is with hypomotor seizure. The topics, the second, third, and fourth topics will be very short. The second one is on invasive evaluations. I always talk about stereo EEG. Hopefully in the future, we can have cheaper electrodes and can offer with insurance coverage and can be offered to more patients. Stereo EEG is to put electrodes directly into the brain. So it can capture a deep structure. It can do bilateral implantations. It can involve the insular, can record the cingulates, which are deeper in the brain that cannot or not very well record by the scalp EEG or subdural EEG. So this patient has a frontal lobe epilepsy. The video I've shown you yesterday, the one who played drums, and the EEG just show a subtle frontal discharges, and in stereo EEG, we identify a clear area of ictal onset, and this patient had, he had radio ablations and he's seizure-free since 2020. So just an announcement, there is a SEG course in Bangkok. The price is a bit expensive. I'm asking for a discount for Vietnam. Hopefully we'll get that soon, and then you can join us. So third topic is on epilepsy surgery. I'm not going to talk about resective surgery. I'll mainly focus on minimally invasive surgery, which is ablations. The non-invasive one are like focused ultrasound. So this is a patient that I've mentioned just now. the one that we did SEG, the one who played drums, and there is a hypermetabolic regions in the left frontal lobe over here, but the MRI was normal. So the SEG identified a very tiny area that causing the seizure, and we do a radio frequency ablation in 2020, and patient is seizure-free until now. Just imagine he had 5 to 10 seizures a day, has been seeing multiple psychiatrists because he was thought to be psychogenic. This is a picture I get from Dr. Chong Wong from Sydney Westmeath Hospital. This is MR guided lead, which is laser interstitial thermal therapy. To show you the real-time picture, because when the electrode is put in one spot and the temperature is increased, it will be shown on the thermometry on the first left picture, right? This is thermometry showing the temperature, okay? In the middle is ablation estimates to show you how big is the final lesion will be if we do a post-op MRI. And the third is a post-op MRI showing the actual ablated lesions, which is corresponding to the ablation estimates in the middle row. So this will be our future. What happened is our radio frequency ablations, we are unable to estimate the size. We are unable to definitely be certain about the location. Whereas lead will give you or give us the answer, real-time answer. Focus ultrasound is new. It's not invasive. There's no operation. It's mainly used ultrasound focus at certain point, which cause ablation, right? So it's an ablation but non-invasive, and we are hoping to see this in more area. This is currently available in Taiwan for research. So the last topic is neuromodulation. A lot of you know VNS. I'll just talk a little bit on DBS and other non-invasive neuromodulations. So deep brain stimulation is getting more popular. Deep brain stimulation is usually used for Parkinson's disease. But in epilepsy, we can put it in anterior thalamic nucleus. We can put it in the central medial nucleus. We have our first case last year in January. A patient with bilateral temporal lobe epilepsy. I suggest to put electrodes and to see whether the left or the right are the seizure onsets. But patient refused because his director, he doesn't want resections, he doesn't want memory loss. So I suggest, why don't we think about neuromodulation, and his company can cover deep brain stimulations. He had 4 to 5 seizures a month. Now, he has only aura, occasional aura. He's flying everywhere, including Vietnam. He is the director now stationed he's a Philippines, staying in Indonesia, flying everywhere. And he's so happy with a deep brain stimulations. Other things we do is repetitive transcranial TMS, and we have a TMS machine and workshop here. This is used for many different diseases like stroke, depression, and so on. Can be used for seizure. In our series, the effect lasts about 6 to 8 months. If the patient is responsive after 6 to 8 months, patient have to have a repeat course of 10 sessions, once a day for 2 weeks from Monday to Friday. And another one is VNS, but transcutaneous, and the electrodes is put in the vagal nerve branch over the auricular regions. The response we have tried on 4 patients. So far, I have one patient who had very frequent seizures, supposed to go for stereo EEG, and she is seizure-free now. The next one is direct current stimulation. The current is very small in amplitudes. I use it mainly for motor cortex seizure or sensory cortex seizure. It helps to reduce the frequency, but not totally seizure-free. In conclusion, I've covered the advances in non-invasive pre-surgical evaluations as listed. The invasive pre-surgical evaluations, mainly stereo EEG. Then the next is epilepsy surgery, minimally invasive surgery, neuromodulations. And just announcements. This is our ASNA 2023 in Da Nang. The next one will be 2025 in Bali, 6 to 9 August. So please mark your calendar. ICCN, I don't need to introduce because Prof. Notina has introduced that. So the stereo EEG course, I've asked for discount. Hopefully you will get it soon. And the last one is the Asian Oceanian Epilepsy Congress, which is supposed to be in November, has been postponed to February. Thank you.